One thing that everyone's talking about is the LEADER study on Monday. That will be a detailed analysis of what appears to be a level of cardiovascular protection impacted or produced or provided by liraglutide. And the top line numbers were released some months ago, but no one knows the details of the extent or how robust the cardiovascular reduction is. So it's on everyone's mind. Also at this meeting were some very interesting presentations and elaborations on the EMPA-REG study and why patients had an improved cardiovascular survival. Very provocative presentations yesterday by Dr. Farinini and the one following it on renal issues related to EMPA-REG. Very provocative and actually a very sound thesis as to why patients did so much better with empagliflozin. That was a highlight for many of us this meeting. Of course, I also have been impressed with a number of posters, including the one we'll talk about now, the one that shows a very substantial reduction in glucose fluctuations using once-weekly exenatide. I think it's it's a nice poster. The data is very clean and very graphic, and it shows in a simple way that if you look hard enough, you're going to find that patients, even with good A1Cs, have significant blood glucose fluctuations. A1C tells us on average glucose over 2 to 3 months. A fasting blood sugar is 1 point in time. A random blood sugar is 1 point in time. What we don't know is what's going on all the time with blood sugars before eating it, right after eating, 1 and 2 hours after eating. The only way to determine that is with a continuous glucose monitor. So that was done. A continuous glucose monitor was applied to type 2 diabetics, some on metformin alone and some on once-weekly exenatide. The differences were quite striking. The amount of time that patients spent in the blood sugar range greater than 180 was very significantly reduced by in the exenatide group, and obviously no change in the metformin group, but not at the expense of hypoglycemia. There was no increase in hypoglycemia. The amount of time spent between 70 and 180 was greatly increased by the exenatide group once weekly and not changed by the metformin group, and it was really a very robust difference. In addition, both fasting, mean, and postprandial glucose levels were very significantly affected and improved by the exenatide once-weekly preparation. In fact, postprandial glucose levels went down as much as 44 milligrams per cent. I think that's important. I think postprandial excursions are potentially quite harmful. We have very robust epidemiologic evidence to suggest that, and we have very substantial experimental evidence to suggest that postprandial excursions are harmful directly to the endothelium, also producing an increase in oxidative load on the body, production of urinary products that are related to oxidative stress. Postprandial excursions increase the pro-inflammatory milieu and the coagulability, pro-coagulable state. So there's a lot of reasons I think clinically we want to avoid the postprandial excursions. And once again, with once-weekly exenatide in this study, the postprandial excursion was reduced by 44 milligrams per cent, which is pretty substantial. I think most type 2 persons with diabetes who have and demonstrate unacceptable post-meal excursions, this would be an extremely effective way in reducing those excursions. So that's a fairly large body of people. Well, it's a GLP-1 agonist, and it's once weekly, and all GLP-1 agonists share many of the same adverse events. This one has one that's a little bit unique, a little nodule formation as you inject it because of the suspension of the microspheres. It's not usually a painful nodule. It's a little bump that usually goes away by the next injection. There's a high incidence of nodule formation, though, that patients sometimes know but rarely stop the drug because of. But the most common side effects of all the GLP-1s, including this drug, is nausea, GI-related symptoms. And that does occur, and it did occur in this study to an extent greater than the control group, but in my clinical practice is usually quite transient and over a period of weeks goes away. You never can predict who may get mild nausea or not, so there's really no reason to not try this drug on anyone, except for those with contraindications. I mean, there are some contraindications to GLP-1s in general. I mean, one is a history of medullary cancer of the thyroid, which is really quite rare, and the other is a history of idiopathic recurrent pancreatitis. While not a strict contraindication, it's advised not to use this class of drugs with that history. There are a number of GLP-1s. I mean, the introduction of the incretin-based therapies has been monumental. You really can't practice diabetes today without having some form of incretin-based therapy on board. What I think this medication offers, and we don't know about the others because CGM studies have not been done, continuous glucose monitors, but now that we know that there's a very robust reduction in glucose excursions with extended release exenatide, I think it offers something that the other GLP-1s cannot yet say. There's not any particular reason to think some of this won't be shared by the others, but they haven't done the studies. And the CGM study is here and now, and it does show a very nice reduction in postprandial excursions. And I think it's something that we can offer our patients when their A1C isn't where it ought to be, or if it is, but the postprandial excursions are still excessive.